All right, you guys, here we are, another episode, and I have a very special guest on today, Dr. Jordan Feigenbaum. Welcome.
Thank you so much for having me. Excited to be here.
I am so happy that you're on today. You guys, Dr. Jordan Feigenbaum is the founder of Barbell Medicine, and I'll tell you a little bit about Barbell Medicine, and then he can talk about it. It is a company to start in 2012. Am I right?
Mm-hmm. Yep.
Okay. And it promotes health and successful aging by bringing the best of modern medicine together with strength, conditioning, and nutrition.
Mm-hmm.
Pulled that right from the web.
Yeah, I like that. Yeah. I should write that down. Yeah, that works.
Yeah. So tell us a little bit. So that's why I wanted you on. You guys, I've listened to Dr. Jordan. Can I call you that? Or Dr.
That's fine.
Feigenbaum?
Jordan's
Right.
fine. Jordan's fine. Yes.
Right.
Yes.
I have listened to Jordan for many, many years. He has been kind of a little sound bites in my head during my cardio sessions, and really one of the main players of sources of information that I like to bring to not only my community, my clients, family members that ask about health, because it's just straight up legit and real. So it's really hard to find some information in the internet space that you can trust. So Jordan has been one of those few podcasts that's in my ear. He has lots and lots of episodes, probably about 300 at this point. Yeah. So tell us a little bit about Barbell Medicine, maybe why you started it.
Sure.
You want to start there?
Yeah, no, it's kind of I think like most people in this space, you get into it due to a personal interest. Most people get into it, whether it's personal training or even medicine. There's some sort of interest level there, right? And so for me, I started working out. I started exercising after I dislocated my hip. I dislocated my hip racing dirt bikes. This just goes back to poor decision making. But and then I really fell in love with it. So that was kind of my introduction into training. And then was a director of education for a large personal training company, kind of ran my own gym for a little bit, and then went to medical school shortly thereafter. So when I got to medical school, I noticed that pretty much every time we would learn about a new disease pathology or condition or whatever, there was a lot of what I would consider just lip service being paid to lifestyle change. There was always a mention of exercise or eating a health promoting dietary pattern. Usually that wasn't the nomenclature that was used, but it was always mentioned, right? And so I thought, well, why aren't we learning about exercise, like not only what types of exercise or like how to recommend exercise to patients, how to make sure that they do it, how to assess if they're currently exercising, just what you would want to do with effectively any other sort of behavior, right? So I was kind of like, this seems like it's lacking, but honestly, it's my first year. I don't know. Maybe I just am out of my depths here.
Yeah.
And it kept becoming more and more clear that doctors in general don't know much about exercise, which on some level is fine because you want your doctor to operate up to their level of training, right? You don't go to see them for exercise recommendations. You go see them because you have a concern or an illness or an injury, something like that, potentially. Yeah. But you also don't want them to dissuade people from exercise, thing one. And then thing two, you don't want them to miss an opportunity to recommend lifestyle change if that would be effective. So I'm not going to talk a ton of numbers, but this is kind of what led me to form the not only the company, but I start the website, do the whole thing. When you survey primary care doctors, so people see folks for whatever reason, less than 10% of them know about the current physical activity guidelines. So that's like strike one, right? Of that 10%, less than half of them will actually recommend that to their patients. And so you're like, wow, big opportunity there. And then it gets kind of even worse / juicier at the same point. There is the statistic in medicine called number needed to treat. So how many people would you have to see? Would you have to treat with a specific intervention to get a particular outcome? For exercise, the number of patients that a doctor has to counsel to start exercising for them to start and then keep doing it for a year is 12. Right. And the average primary care doctor sees 20 plus patients a day. And so I'm like, okay, look, if we can get our numbers up where instead of only 10% of doctors knowing this, but maybe it's 30%, 40%. And then even if half of them are recommending exercise to their patients, we could get a lot of people to start exercising. So what are the reasons why doctors aren't doing this? Well, one, they don't do it themselves. That's problem. Number one, if they don't. Two, they're unfamiliar with, they feel like they don't have enough knowledge about exercise. So that's problem number two. And then three, they don't have any materials that they can give their patients on how to exercise. And I'm like, I did this for a long time. I feel like if there's anybody out there who's better suited to marrying training, exercise, and medicine, like they haven't done this yet, so I guess I'll do it. And that's kind
Yeah.
of how barbell medicine started. And so that's been our core mission. We want more people to exercise, more people to feel empowered, taking their health into their own hands, and feel like they play an active role in their health trajectory. And we want to do that through lifestyle change. But we also don't want to negate the advances in modern medicine either. And so there was this sort of on
Yeah.
the back end, coming from the fitness world as a trainer, as a coach, I was like, man, I don't really know a whole lot about medical conditions. High blood pressure, I know what it is, but not like what's the effect of exercise on this outside of just generally making it better. Same thing with like type 2 diabetes or cancer risk reduction. And you keep going down the list. And I'm like, well, what if we could provide resources for trainers and coaches too, as far as like how exercise can modify a particular disease or any specific considerations about a specific disease that might help them not only motivate people in their community to start exercising, but also empower the coach or the trainer to feel more comfortable having the person with high blood pressure lift heavy weights, for example, when previously they were worried about that for no particular reason other than thinking this is probably bad. It's like, well, what does the scientific evidence say? So long way of saying, I thought we could like fill this niche in the scientific communication space, health promotion space by blending the best of modern medicine and strength conditioning together. And nobody did it before me, I guess, at least that I could tell on a larger scale. And we keep plugging away here. That's how barbell medicine came to be. So
yeah, no, I love it. And I think a lot of fitness professionals, at least that have been around as long as I am, as I have, I've been here my whole adult life,
Yep.
Have always wanted kind of that we want a prescription for exercise, essentially.
Yep.
Is kind of what it would kind of boil down to, right? Because you get people, like you said, they are unfamiliar. Doctors are unfamiliar with exercise, and I tell that to my patients in cardiac rehab too, because these people, most of them are a little bit older, and they're a little maybe older thinking, and maybe afraid of exercise, or just don't know, or maybe they're 70 or 80 and have never considered lifting weights before. And this is kind of their first understanding, but the only reason they're there is because their doctor told them to come to us.
Totally.
Because of their event. So it is a prescription, but at the same time, they say, well, my doctor never said anything about, like you said, about exercise my whole entire life, leading up to these events that they think they suddenly had, when you and I both know they aren't sudden. They're a buildup over time. And they hold their doctors on this pedestal of information that they think they should know everything.
Yeah.
And I do explain to them, you came here mostly primarily from their cardiologist that are there to help you with your heart when you have been having issues. That is their job, is to understand your heart and to keep you going with what you have going on now. And they have, thankfully, a resource to prescribe them to a clinic like mine or what have you. But outside of that, I think the expectation of physicians knowing all the things about exercise, it's a little bit much, because that, again, like you said, that is not really essentially their job to know all the things about exercise. That's where that kind of like that bridging of that gap that you are there. And I just like to remind people that, like, it's not if you have cancer, you want your cancer doctor to cure your cancer. And that would be the thing they're going with, a side of exercise. Hopefully they can educate some, but you want them to take care of you in that manner too. So I think people, and I think maybe generations, ahead of me and you, think a little bit more like that. So I feel like you're starting to maybe change that, number one, of the patients and the people to understand, hey, a lot of doctors don't know everything about this. But here is this barbell medicine that can kind of come in and maybe fill that gap, which I love. Again, fitness professionals of my generation are like, yes, this is what we need.
Yeah, it's interesting. Maybe on the pendulum almost is swinging like kind of the other way. I agree. Certainly, our generation and certainly generations before ours would almost, default to, oh, well, the doctor said this, I'm doing what the doctor said, right? Which pluses and minuses to that. I don't know that I subscribe to this maybe patriarchal relationship between doctor and patient. So that's another podcast. But now what you see, especially on social media, so this is probably amplified to some degree in my perception, but where people say, "Oh, my doctor said this," and this particular stupid thing, whether it's
Yeah.
don't eat carbs or, don't lift heavy weights or,
Yeah.
whatever. And to the patient's credit, yeah, those are dumb things to say. And
Hmm.
so I don't know if the doctors are feeling a responsibility to have an answer for everything rather than saying I don't know, which would be a
Yeah.
perfectly
Yeah.
fine answer. I just think that yeah, operating outside of your depths of expertise in general is a bad idea. And so my thought was rather than chastise the doctors, because do you know how much traffic and how much social media attention and audience we could garner by just slamming doctors, throwing them under the
Oh,
bus and
yeah.
say,
Yeah.
but I don't want to do that. I want them on our side. Like I view them as
Sure.
part of the solution, right? So, hey, look, it's fine if you're not an exercise expert. I don't want you to be. To your
Yeah.
point earlier about cancer, right? There's a whole field of exercise oncology, which is even I don't feel super comfortable getting into the weeds there with very specific types of cancer and the role of exercise and certain risks and stuff. There's some nuance there, if you will.
Hmm.
Uh, and I wouldn't expect an oncologist to potentially know all of that. However, I would expect them to be aware of that and then be able to refer appropriately or, say,
Absolutely.
hey, I don't know, and I will find this out from the expert in the field, and then we can come up with a shared plan together. And so I think introducing clinicians, other healthcare professionals, and even fitness professionals to sort of these resources is beneficial rather than having to pretend like there's this adversarial relationship or you have to know things and be the like sole proprietor of all the info in the space. It's like that's impossible. It's just
Yeah.
not possible. So I think yeah, if we can help both sides out, I think that's how we move towards a solution rather than either just defaulting to what the doctor says or just
Hmm.
rejecting it wholesale because they don't happen to be an expert in a particular space. So we're trying our best. We could use everyone's help. We'll keep plugging away.
Yeah. Yeah. And I think that's one reason why I allow you all to be in my ear.
Sure.
Because and why I promote that because you have a nice way of correcting people and not making them, and I've noticed some comments that you have meant that you've said online and on Instagram and what have you, uh of not making them feel bad for asking questions and not making them feel bad for not knowing. And also, even when you don't agree with somebody and something that they're saying, you're not disrespecting that person as an individual.
Mhm.
You hope to kind of take their information down so that it's not harmful, because there is some harmful misinformation. And just like you said, even doctors are just people that
Mhm.
are specializing in one area and trying to help, and what they think is helpful. And oftentimes, I even have my own patients or clients say, "Well, my doctor told me," just like you said, they found this other doctor on YouTube, and they said not to eat carbs, or they said cholesterol doesn't matter, and
Yeah,
and
yeah.
they fight me in the program the whole time that is laid out very scientifically based to help them because of the pushback that their doctor one time told them, not that cholesterol doesn't matter. Your high
Yeah.
cholesterol doesn't matter.
Yeah.
And so that in turn can be harmful. But you have a very kind way to not disrespect the individual and hopeful that they can learn from you as well. So
Yeah, well, I appreciate you
it's a
saying
good
that.
thing.
Certainly, it's an aspirational goal. You wanna respect people as humans, right? And you
Mhm.
want to allow them to kind of come to their own conclusions based on, the evidence available or data sets and such if they value that. But ultimately, it's not so much about, quote, like, changing minds. I think as I've become more mature over the years, this is kind of like
Yeah.
something that's come up, and so, yeah, I don't maybe to paraphrase a friend of mine, this is not her quote, but she said this all the time. She's like, you can catch more flies being sweet than than if,
Yeah,
than if you're sour all the time.
absolutely.
And I'm like, yeah, that's true. And the point isn't, again, if there's misinformation, sure, that's annoying. Sure, kind of all agree like that should probably be countered, but you don't have to be a jerk about it. And
Yeah,
I've definitely
for
made
sure.
mistakes in the past. That's how I'm getting better at it. And I appreciate you saying that. We'll try, like I said, keep plugging away, and hopefully your listeners, if we can answer some of their questions here, maybe it'll challenge some of their beliefs. And I hope that they understand I'm not doing this from a position of like I'm the authority or
Yeah.
you're wrong, I'm right. But this is just kind of my current beliefs based on existing
What
evidence if it
you know
exists.
now
Mhm.
and all of the
Subject to
collection
change.
that you've done. Yes,
Subject to
absolutely.
change. Yep.
Yeah. So AKA no need to be a jerk face about things
I
to
like
people.
that. I like
Yes.
that. Yeah. In general
So
rule, that's a good rule to live by.
This is Jordan Feigenbaum, the non-jerk face.
Yeah, new and improved.
Yes. So let's get into a little bit. So you talked really briefly, and this is one thing that I did want to talk about, because my patients and my clients alike, the blood pressure response to training.
Mhm.
I see it. I am not a clinical person. I am a director of a cardiac rehab. I make sure everybody has their things to do their jobs.
Mhm.
However, I understand it a little bit more now, being there, in that clinical setting. But let's talk about the blood pressure response, because a lot of people think they can't work out because they have high blood pressure, when in turn they actually should. So can you talk about that?
Yeah. Yeah. So obviously, blood pressure just measures the force of the blood traveling through the blood vessels. And we know that resting high blood pressure, if it's elevated for a long period of time, is harmful to health. And so, a couple key things in there: one, resting blood pressure. So, what your blood pressure is just sitting around or at work, otherwise not being terribly physically active. That's be your resting blood pressure. And if it's elevated for extended periods of time, I don't mean a day or a week or a month. I'm talking about years and years. And so it's
Mhm.
kind of a cumulative exposure to elevated blood pressure. That's the issue, particularly at rest. And so there are a number of ways to measure this. You can do this in the doctor's office with the blood pressure cuff. You can do this with an ambulatory blood pressure monitoring device, which is a fancy way of saying a blood pressure monitor that you wear around as you go about your life. And so that will kind of give you a better or broader picture of what your blood pressure is on a, over the course of a day while you sleep and so on. And so, yes, we know that elevated blood pressure that is sustained for a long period of time increases risk of cardiovascular disease. So that includes things like heart attack, stroke, blood clots, pulmonary embolisms, goes on and on and on. It's also correlated with a lot of other disease states. So type 2 diabetes is one of the first presenting signs of insulin resistance, which later on leads to type 2 diabetes, is high blood pressure. So anyway, it's not that they're connected necessarily by, some direct sort of mechanism, but the underlying driver of high blood pressure is probably related to some development of these other conditions. And so, yes, you're exactly correct. There's a concern that because all physical activity increases blood pressure while you're doing it, that maybe that would lead to a worsening of somebody's resting blood pressure. So blood pressure goes up with exercise in lockstep or in correlation to how much muscle mass is being used, the
Mhm.
intensity of that activity. So more muscle mass, higher intensity, higher blood pressure, and also the actual type of exercise itself. If there is an isometric component, meaning that the muscles are producing force but not changing length, that tends to produce an even higher increase in blood pressure while you're doing it. Most types of weightlifting have an isometric component in addition to a dynamic component where people are actively moving. And so if you had to rate exercises from like minimal blood pressure increase to like maximal blood pressure increase, the minimal one would be like swimming,
Okay.
because there's really no isometric component. The blood
Mhm.
pressure, your blood flow is not really fighting gravity since you're horizontal, right?
Mhm.
And it's really hard to do at super high intensities. But higher
Yeah.
intensity swimming would have a greater blood pressure increase on average than just doggy paddling, for example.
Yeah.
So that's on the low end. On the
Mhm.
high end would be something like a 1 rep max squat or deadlift. Not only because the weight's very high, but a lot of muscle mass is being used. There are
Mhm.
isometric components to both movements, and you're doing a Valsalva. So you've kind of layered on all of these additional things that can increase blood pressure while you're doing it. In fact, blood pressure was measured in a group of individuals doing leg press at successively heavier weights: 50%, 65%, 70%, 85%, 95%. One of the guys, when they were leg pressing 95% of their 1 rep max, their blood pressure was 400 and something over 250,
Oh,
whereas a
wow.
normal, yeah. So whereas a
Yeah.
normal blood pressure is, less than 120 over 80. And so
Yeah.
people, when they hear those numbers, even clinicians are like, yo, that's
Yeah.
high.
Whoa.
And so your assumption is badness. If high blood pressure is bad, if we just take that out at its face value, then, well, it's got to
Mhm.
be bad when you're exercising too. However, when you go look at the evidence, well, what does resistance training do? Participation in resistance training, what does it do to resting blood pressure? And on
Mhm.
average, it lowers resting blood pressure,
Mhm.
period. And that's for people with normal blood pressure or high blood pressure. As we
Yeah.
dig in a little further, well, what does it do to people with high blood pressure? Does it lower it a lot or a little? Because if it's just a little, maybe that's not our recommended sort of exercise modality for reducing blood pressure or managing blood pressure, for
Mhm.
example. It looks like for people with high blood pressure, so that's greater than 140, for example, systolic, whereas 120 or below would be normal. It looks like resistance training has the same effect on lowering blood pressure as aerobic training or endurance training. It
Okay.
lowers resting blood pressure by about 8 millimeters of mercury. So if you were at 140 over 85 per se, now we're shooting for an average of like 132 or something over 80 something.
Yeah.
Not bad. And that's whether it's endurance training or resistance training by themselves. If you combine
Mhm.
it together, now you're looking at an average decrease of about 14 millimeters of mercury.
So
And
it's
you're like,
better with the two.
yes, because we think that there's this dose-dependent relationship between exercise volume and blood
Mhm.
pressure lowering potential. Effectively, the more exercise you do, the more the blood pressure is going to go down
Mhm.
as a general heuristic or rule there. But doesn't look like cardio is better than resistance training. They both do it, just it's slightly different mechanisms. And the
Mhm.
magnitude of effect is related to how much exercise you're actually doing. So that's
Mhm.
thing one. So we've established already exercise resistance training, even if you have high blood pressure, can be beneficial at lowering your blood pressure. That's thing one. Thing two, you're like, well, okay, that may be well and good, but isn't there some risk to driving blood pressure up that high? Like, won't
Yeah.
people have more strokes, blood clots, heart attacks, something with exercise if they have high blood pressure and are pushing the intensity, for example, or lifting heavy weights?
So
And
their
as best
working, blood pressure would be high, and with the hopes of their resting when they're done be low.
Yeah, that's exactly what we
Yeah.
see, and in fact,
Mhm.
post-workout, there's this interesting phenomenon called post-exercise hypotension,
Mhm.
PEH, and that
Mhm.
seems to be commensurate or proportional to how high somebody's resting blood pressure is. So
Mhm.
if, for example, your resting blood pressure was normal compared to an individual with elevated resting blood pressure, after a workout, theirs is gonna be far more decreased than yours
Yeah.
is as a
Yeah.
sort of response.
Mhm.
But there's this thought that, oh, well, if you have resting blood pressure that's high, and then you exercise, especially heavy, and your blood pressure goes up even higher, well, that's a risk factor. And there
Mm.
doesn't seem to be any evidence to support that, whether we're talking case reports from people who have, high blood pressure related sort of side effects. Those don't proportionally occur in folks at a greater rate who do have elevated blood pressure. In fact, like exercise seems relatively safe overall, just as a general sort of rule. So we can kind of get rid of that notion as well. The third part of this is that, okay, if you have somebody with elevated blood pressure and they start exercising, they're doing both cardio and resistance training as we would have advised. Well, how does that compare to just taking medication? Right. And so in this recent study, 2018, is 391 trials. Half of them looked at exercise and its effect on blood pressure. The other half looked at antihypertensive medications and their effect on resting blood pressure. And when you restrict that analysis just to folks with elevated blood pressure, exercise has a larger effect on resting blood pressure than the antihypertensives,
Yeah.
just a larger
Yeah.
effect. And so it doesn't mean that if you're on an antihypertensive, if you're listening to this right now and you take a high blood pressure medication, we're not saying stop, but we're saying
Yeah.
that exercise is a big lever you could potentially pull. And we would want folks to do that, particularly if they're able to do so. So that's the story. If you want to simplify soundbite, here we go.
Yeah.
All activity raises blood pressure.
Mhm.
All activity raises blood pressure. To our current knowledge, no activity, physical activity, exercise, raises resting blood pressure. In fact, just the opposite. Effectively, all exercise, all activity that we've studied lowers resting blood pressure proportional to the amount of exercise you're actually doing.
Mm.
So more
Yeah.
exercise in general is better.
Cardio and resistance training, folks.
You prefer both. You would prefer
Yeah.
both. Yeah.
Yeah.
Mainly because they work through slightly different mechanisms to affect resting blood pressure. And so if you were trying to get the maximum sort of blood pressure lowering effect, you would do both, and you would do a lot of both.
Mhm.
Yeah.
And they're equally as important for the overall health of your body.
I would say so. Yeah. When people ask, oh, what should I do, cardio or weights? And I'm like, I don't like being backed into this corner, and I would
Yeah.
prefer you do both. Like, can
Yeah.
we just start from that? Yeah.
Yeah. How about we just don't ask that question and we just
Maybe don't ask.
assume both?
It's
Yeah.
kind of like asking, like, if you could only do one exercise for the rest of your life, like, what would you do? And I'm like, I don't know, man. Eat? Is that
Yeah,
exercise?
yeah.
'Cause
I don't have to answer this.
yeah, yeah, yeah. So
Uh, so, okay, so the blood pressure, we got that. Let's say somebody's on blood pressure medication and they're exercising. Would they have the goal of kind of exercising, getting their blood pressure monitored, whether it's at home or through their physician, and then lowering that medication? Would that be kind of a goal to
yeah,
be
I mean,
monitored that way?
Yeah, I mean, you don't get any gold stars for going through life without medicines, right? So, like,
Yes, I
I don't
love that.
yeah,
Yeah.
so, I well, that said, I do think, there are no biological free lunches, right? Medications have some sort of risk profile associated with them. Some of them are relatively benign, and so maybe it's not a huge deal, but I think, from a goal setting perspective, a lot of the goal, how people come up with them, it has to do with their own personal value systems and their
Mhm,
beliefs, right? So, if
mhm,
not being on a medication or using a lower dose that's important to them, as a
mhm.
coach, as a clinician, you could pull that motivation lever and say, well, look, we could potentially reduce your dose, or you could be
Yeah,
off this medication completely, which
yeah.
is great. We see that all the
Mhm,
time in individuals with not only high blood pressure, but also individuals with diabetes, type 2 diabetes,
mhm.
that once they
Yeah,
start exercising, they get to lower their medication use.
yeah.
And
Mhm,
I would tend to favor that's generally better than being on higher levels of medication. Although, again, I will say the goal may not be to like get off all medications. It doesn't
yeah.
have to be that goal, because
I
some
mean, it
folks
can
will.
be more cost effective for people if they don't have to
Totally.
take medication.
Totally. Absolutely. Yeah, absolutely. And there are some medications again with that have risk profiles that are generally unacceptable on some level, and so
Yeah,
you would
yeah.
prefer folks to use less medication if possible.
Mhm,
But the main goal here, I think, from a clinical standpoint, is achieving a resting blood pressure that does not increase risk of heart disease or other medical conditions due to the cumulative exposure to a known risk factor. In this
mhm.
case, elevated resting blood pressure. So if
Yeah,
we can do it with lifestyle change alone, great. If we need to do
yep,
lifestyle change and some medications, also great. The important part is get somebody to goal. And I think that's the general lens we should be looking through, that intersection of like exercise and medication. It's like,
yeah.
what is the clinical endpoint that we're looking for? And then
Mhm,
how can we achieve this it's like an equalizer. Do we turn the
yeah.
exercise up, lifestyle up? Do we turn the medication up? Like, what do we need to do to get somebody to that goal?
Sure, because everybody's gonna be different and everybody
Absolutely.
responds differently, and
Yep.
everybody's lifestyle is a little different with genetic components and all of the things.
Absolutely,
Yeah.
100%. Yep,
Yeah, yeah, and
yep,
I wanna backtrack just for 1 second, and that's when I
sure.
think you said that a while ago when I was listening to one of your podcasts, and I've used that several times, and it was helpful. You said you don't get a gold star for not taking medication.
Yep.
Nobody at your funeral is going to say, "Pam did not take, X, Y, and Z medications her whole
Sh
life." Nobody cares.
she did it pharma free, like, come
Yes.
on, it's not on anybody's
You know?
headstone, yeah,
I
yeah.
love that, and you said that it was probably a few years back, and maybe you've said it several times.
Mhm,
But I have used that with my clients and my patients alike because I think it's an important thing to remember is that you don't win an award for not using all of the modalities that we have in 2024,
totally.
um, because there's a lot of things that we should be grateful for that we have today.
Yeah,
Um,
yep.
yeah,
No, I
so and again, be monitored because sometimes if you're lowering your blood pressure or, maybe your cholesterol with, lifestyle modifications, then the medication may be too much for you, so that's when you have to, be in line with your physician and monitor and all of those things.
Yeah, I think, that actually brings up maybe a core principle that we discuss indirectly in a lot of our content relating to medical conditions and how this can be modified by not only exercise, dietary pattern change, lifestyle, other lifestyle changes, and medicines. It's, well, again, what is the end goal? And is
Mhm.
this like agreed upon between you and your provider? And so this should be a
Yeah,
shared treatment plan between you and the
yes.
provider. So there should be discussion. And so in a perfect world, let's say somebody just recently received a diagnosis of elevated blood pressure, high blood pressure, and they're like, "Oh no, like okay, well now I'm motivated. I want to change this. I'm going to make X, Y, and Z changes."
Mhm.
Great. There should have been in that conversation about the diagnosis, like, well, look, here's what I'm willing to do, or here's what I'm going to try to do. Here's what we are going
Yeah.
to try to do with you to get to this end goal. And so, as the patient, at that point, I'd say, well, look, if I can get my blood pressure to X with just lifestyle alone or lifestyle medications, when do we get to start discussing taking less medication, if that is a goal for some individual? Or is it possible that by initiating exercise in addition to this medication, that I'll need a different dose in the future? And again, having
Mhm.
those, just setting the expectations, I think is, yeah, part of the art of medicine. But I do
Yeah.
find that due to the time limitations and maybe jadedness of some providers, which I can understand and relate to, you have the patient sitting in front of you and you're doing this dance, like, and you should start
Mhm.
exercising and do this and eat better and yada yada. And even if you explain, very specific actionable items, the assumption may be, yeah, the patient's not going to do this, unfortunately,
Yeah.
which
Yeah.
that kind of is what it is. I hate saying that, but I think that is a general assumption, and unfortunately, it's not that far off the truth, right?
No.
And so,
Yeah.
the doctor and the patient are doing some sort of this dance here. And it's like, yeah, I want you to exercise, and the patient's like, yeah, I'm gonna exercise. But there's no the final part of that conversation would be like, and we're gonna keep monitoring your blood pressure at these
Yeah.
intervals to see how you're responding, so that we can get you to your blood pressure goal. We'll adjust things
Mhm.
as necessary. I think that's
Yeah.
implied, but I think if it's directly stated, maybe that there's this expectation that's being set for the long-term trajectory of a person. And I try to do that when I talk to people about their different medical conditions, but I have the
Mhm.
benefit of having almost unlimited time with folks. Whereas if you got to see people 3 minutes, 4 minutes, 5 minutes, that's really difficult to do. So I empathize with the providers, and they're trying their best, and I fully appreciate their efforts here.
There are a lot more, I think, that people give credit to, physicians that wish they could spend more time
Totally.
and wish they had a resource. And again, I feel very fortunate to have what we have here with our ICR, because it is a place that these physicians, cardiologists mostly, can send their patients essentially, only for 12 weeks, but at least it's 12 weeks. And they know what's going to be prescribed, monitored, and sent to them on a weekly basis.
Yep.
And they know what we're going to be giving them in regards to resistance and cardio training.
Hmm.
Now, the patients still don't comply. Sometimes they
Yeah.
don't show up. We can't make them show up.
Yep.
Um, I'm a pretty good salesperson when it comes to exercise, but I still can't get everybody to come. Um, you know,
Yeah, no,
but
exercise participation and adherence is right up there with, nutrition, adherence.
yeah,
I think a
we
lot of,
teach both.
some of it. What's that?
I said we teach both,
Yeah,
and
yeah. Yeah,
yeah.
the fund of knowledge stuff is very important. I agree. Like, people need to know what they should eat, what their groceries list should look like, how to
Mhm,
cook, how to prepare food, how to store food safely,
mhm,
things of that nature. Same thing with exercise. People need to know what to do in the gym, not only to empower them to, like, go,
mhm,
right,
mhm.
but also, like, stick to a plan that works for them,
Yeah,
and so on. That's all well and good, but in my estimation, that's probably a fraction of what needs to change in order to
mhm,
get the participation rate up in not only exercise, but eating a health promoting dietary pattern. Right now, huge
mhm.
problems with people having access to places to exercise. Now, whether
Yeah,
that's just, oh, there's not a gym nearby, or it's not affordable, or it has something to do with somebody's occupational work schedule, or they got
mhm,
kids. How do you create some free time? A lot of problems there, and that's for folks in a particular socioeconomic status where that is even an opportunity for them.
yeah,
And then you go into food and you start talking about the food environment, and things get real murky real quick. And
mhm,
so I need people that are listening to this to know that I don't think this is like a pull yourself up by the bootstraps sort of thing and just start exercising or start
yeah,
eating well. I think that there are multiple things conspiring against us for exercise participation and eating a health promoting
absolutely.
dietary
Yep,
pattern. And in a clinical sense, man, it's an uphill battle. So
yep,
again, I acknowledge all of these barriers, and I'm optimistic that we can figure out ways to solve them. But I do think, from my perspective, for where I am as a subject matter expert, I just want to empower clinicians and fitness professionals, and also the general public, to do what they can, with the resources that they have. That's kind of
yeah.
what I'm
And
here for.
everything matters. Everything counts. Everything
Totally.
matters. And it's easy for somebody like myself or for you to say, yeah, go work out. Like,
Why
because
wouldn't
we
you?
like to do it. We like to
Yep.
do it. It's been
Yep.
part of our life and part of our existence for as long as we can remember.
Yeah.
I'm sure you started working out young. I did when I was 13,
Hmm.
started lifting. And so it's easy for me to say, yeah, let's just find time to work out. But it's not easy. And I think I see, and I don't know what you feel about this, but there needs to be a little bit more almost behavioral specialist in this
Yes.
area because
Absolutely.
I have all of the reasons. I have so many resources for people, even again for patients, but also clients. And I have 12-week or 6-week programs, and I have a 12-week program for cardiac patients. But it's the behavior specialist that I don't have. I can't make them do these things, and there needs to
Mhm.
be more of that.
Yeah. Yeah. I mean, I think if you ask somebody, from regardless of their educational background, their socioeconomic status, like whatever, you can go down the list. If you ask them, hey,
Mhm.
do you think exercise is beneficial to you? And they'd be like, yes.
Of
Yeah.
course.
Okay, great. And so then how do
Yeah.
you square that with less than 17% of the entire global population currently meeting any of the physical activity guideline criteria?
Yeah.
It's like, well, people know they should do something, but aren't doing it. You could
Right.
even simplify this. 15% of the American population, adult population, still smokes. And it's been very well established that smoking is generally not beneficial to health. And
Yeah.
so you're like, so you know that smoking's bad for you, but you keep doing it. And they're like, well,
Yeah.
yeah. It's like, well, it's not a knowledge problem, right?
Right.
It's a
Absolutely.
behavior problem. And
Yep.
so leveraging strategies, potentially medications in some cases,
Hmm.
therapy in some cases, environmental change in some cases that
Hmm.
ultimately changes the behavior. That's how you fix these problems. That's how
Yeah.
you make a big difference. Unfortunately, that's more complicated than just saying, well, here's what the data says, and here's what
Yeah.
you should do. Uh, I don't think that that's, communicating different knowledge. I don't think that that's useless. But
That's
I do
it.
think there's limited benefit to some folks.
Yeah, there's not very much benefit to that sort of thing. My mom has passed away, but she was a very severe diabetic and
Mhm,
had all these heart attacks and conditions, and they were all from general poor health
mhm,
and choices. It's not that she didn't know. I was coming up into my career during these times. She
mhm,
knew. And and even if I tried to step out of the way, she had pamphlets and booklets, and I hold my hands like this if you're watching, because the booklets were this big. And at the
mhm,
time I was just like a young personal trainer getting into the field, and I'm like, what is this? And it was
mhm,
all this stuff that she should be doing,
mhm.
meal plans and dietary guidelines, and she just let it get dusty.
Yeah,
There was nobody to hold her accountable, nobody to help her walk through that. And I think some of that is still to this day just kind of handed out. Here's what you should do.
yeah, yeah. You
Leave
check the
it to
box,
them.
right? Yeah, I
Yeah,
gave them stuff. I gave them information, and if they want to
and it's
do it, that
charted that they
yeah,
have it, and,
yeah,
now it's on them, and, again, in a perfect world, in our very small percentage, it's easy for us to say, "Yeah, you got it, let's go." But
yeah. Let's
most
go.
people
Right.
yeah.
Yeah. I think it's better than not doing it, right?
Yeah,
But
'cause you'll
yeah,
get
I
a
mean,
small percent that will, take some bits and pieces at least from it and make some small changes. Um,
absolutely. Yeah. The current dietary guidelines, they're 2020, 2025. People will say all the time, "Oh, dietary guidelines are BS. They're bad." Whatever. I'm like, "Hey,
mhm,
well, what do you think's in the diet,
yeah,
the guy?" And they're like, "Oh, they say food pyramid." I'm like, "Yeah, so the food pyramid hasn't been in the guidelines for 20 years."
yeah,
Just already, like, I would
mhm,
encourage you to maybe review the current dietary guidelines and then just
yeah,
see like what your problems are with them. And then you have to look at that through the lens of almost nobody meets the
yeah,
current dietary guidelines. And
yeah,
so if you had a gripe with the dietary guidelines, it's probably not due to the information in there. The
mhm,
information is probably what I would consider evergreen, like aspirational on some level. Like, yes, people
yeah,
should eat mostly lean proteins, fruits, vegetables, legumes, whatever, whole grains, a lot of fiber, minimally processed foods.
Mediterranean-ish.
Yeah,
Yeah,
limit your sugar intake, whatever. And here are
mhm,
different dietary patterns. All that stuff, in my estimation, is evergreen, but people aren't doing it because there are other
mhm.
things conspiring against them.
So many things, yeah,
Yeah, but the second part of it is if you had a real problem, it would be that, yeah, either not actionable enough or don't give people these sort of behavioral strategies that they can act that like meets them where they're at
yeah,
currently to change
yeah,
the dietary pattern. And that would be my gripe with them. I'm like, okay, great.
mhm,
Information is fine, but like how do people
mhm,
do this in action and how do we increase adherence to them? Because effectively
yeah,
it's single digit percentage right now. It's the same
yep.
thing with the physical activity guidelines. I think they're fine, but like they're not increasing uptake or participation because maybe they're not actionable enough, they're not clear enough, they don't address the root cause of, why people are less physically active, and so
Well,
yeah,
people don't even follow the guidelines on medication or how to put your TV
totally.
together.
Yeah,
They're
yeah,
not gonna read all of the guidelines on things that they have to physically change every single day for the rest of their life.
yeah,
You know what
yeah,
I mean?
so
To
yeah.
to expect that it's kind of broad.
Yeah, yeah, I'm empathetic. It's tough to do. Behavior change is tough regardless of what it is, and so I empathize with folks, and
And
so
anything is better than nothing.
absolutely.
Um,
Yep.
and so I think that social media can definitely kind of, the people that will watch this and the people that will see this are on social media, and it can get real cloudy of, making you feel bad for something that you chose to do, or making you feel like you're wrong because you chose to walk instead of lift with a barbell,
Mhm.
because you hear, it's very confusing for people. So anything's
Sure.
better than nothing. I want to move into, um, we'll kind of transition that into, and I'm going to link a couple of your podcasts here, because you have a whole library. You can search your website. You can search your podcast on Apple Podcasts. You have one on kind of the blood pressure, I believe,
Mhm.
that I did I did save in my notes, and then I saved this one too. It's Stay Strong for Life. It's a kind of a recent-ish one, which I loved and I thought was really relevant to this conversation. Aging and training, kind of why it's so important. And you mentioned the small percentage of people that don't do it. So I guess let's talk about that. It's not too late. So go ahead and talk about that. It's not too late to start.
Never. Yeah. I
Mhm.
mean, the best time to start exercising or lifting weights was yesterday. The second best
Yeah.
time is today.
Yep.
So, and I think it's a nice callback to the what I was discussing on blood pressure, this sort of cumulative
Mhm.
exposure, right? So
Mhm.
the cumulative exposure you have to insufficient physical activity, in this particular case,
Mhm.
insufficient muscle mass, poor muscle function, that
Mhm.
correlates with sort of your disease trajectory or disease
Yep.
risk. And so we would prefer people to build up this big physical 401k,
Mhm.
that if, God forbid, they need to make some withdrawals for, well, they can do so interest
Yeah.
free. So if that's a
Yeah. Yeah.
hospitalization, an illness, some sort of other physical challenge, well, look,
Mhm.
glad you got all this in the bank. The problem is that most people don't exercise, period.
Yeah.
And of the people that do exercise, most people don't lift weights. And so when
Yeah.
you think about it from a musculoskeletal standpoint, we're not just talking about big muscles like a bodybuilder. We're talking about muscles that have a great function. So are strong, good power, which is high velocity strength, coordination, things of that nature. It's like, yeah, these things have an age related decline over
Mhm.
time. And that's due to a whole host of reasons, but primarily is due to poor levels of activity that would otherwise maintain function. That's thing one.
Yeah.
And then thing two, disease states that do happen to increase in frequency as people age, which also, again, reduces activity further and also can directly affect the muscles on some level. And so what you would want somebody to do, especially as they're aging, if you want to age gracefully, you want to age well, you want to maintain functions, you can play with your kids, your grandkids, their kid, whatever, and go on, you have to exercise. And that
Yeah.
exercise has to involve resistance training. Most people, the vast majority of people, will not be able to maintain a desirable amount of muscle function without direct training because their lifestyles do not otherwise
Oh, yeah. Yeah.
do that. There are people, I'm sure, with very active occupations or recreational habits that, that does impart enough stress on the musculoskeletal system to avoid detraining. So muscular atrophy, reductions in strength, things of that nature, or osteoporosis, osteopenia. But that is effectively, in my view, a statistical error when you look at population wide. Very
Yeah.
few people. And so, yeah, you get this question, I think I don't think it actually is representative of what the public at large is worried about. But, in social
Mhm.
media, in our sphere, particularly folks who are geeked out on training, they're like, well, how long can I get strong for? Like, when's going to be my peak? Right.
Okay, so I have to interrupt you really quickly. My husband was like, he's like, ask him about that, and he was just talking about that because, of course, he's in CrossFit and he's still coaching and he's got
Yeah.
training coaches and he's always so proud. He has this 80-year-old client that came and never lifted weights before. She's like, I want to do CrossFit. He's like, okay. So of course
Yeah.
he worked with her very personally,
Hmm.
and and she just got to hang from the bar for the first time,
Amazing.
and and that's a real rare one to come in, right? But he said talk about the when does our maximum strength end,
Yeah.
and so that was something he wanted to talk about, so he'll be happy that you
Y-
talked about that.
Yeah, I mean, I think you can look at this from two different ways, and I'll do that. One is, okay, let's say you started training as a teenager, like, okay, so
Yes.
early on in life, early exposure to sport, to lifting, to exercise in general, and you did that diligently. When would your strength, when would your performance peak? And it differs based on the task. We talking about maximal low velocity strength, like powerlifting. We talk about maximal high velocity strength, Olympic weightlifting. We're talking about mixed modal stuff, CrossFit. Are we talking about track and field, like whatever, right? So there's like slightly
Mhm.
different ages for any particular
Yeah.
task, but most of the time we're talking about 20s to 30s. And that's for a person who
Mhm.
starts training earlier in life. What if someone
Okay.
never, no one someone doesn't exercise until they're 40?
Yeah.
Well, they can be stronger in their 40s than they were in their 20s because they weren't
If they
trained in
have
their
never
20s.
trained before. Yeah.
Or what if somebody picks up a barbell for the first time in their 50s? They could be
Or
stronger in their
ooh,
50s. Well, yeah. At some point there's going to be a decline where, like, yeah, you're in your seventh or eighth decade of life. And even though you're training your face off and you're having a good time and you love it, it's like, yeah, well, I happened to be stronger in my 20s, but I'm
yeah.
certainly stronger in my 80s or 70s now than I was in my 60s.
or
So
50s or so,
yeah,
yeah.
exactly. So
Mhm.
relatively speaking,
Yeah.
probably the most interesting data we have on this is in powerlifters who have been competing for 30, 40 years or whatever.
Mhm.
And it seems like they end up maintaining their performance level into their fifth decade of life. So 40s. And then
Mhm.
afterwards, it tends to kind of go down. And people are like, ah, well, that makes sense. You're in your 50s, your 60s, 70s, just not by a whole lot. Now, granted,
Yeah,
this is selection bias. You have people who got probably pretty strong pretty quickly, who love
sure.
strength training, who are like, elite level athletes. Otherwise, why would they keep participating? That would be like a whole
Yeah,
like
yeah, you have to love it, right?
thing to do. But they're losing single digit percentages of strength over the decades. And you're like, huh, if I could be a similar level of strength that I am now in my 50s, and potentially
Mhm.
60s, maybe it's even 10% less in my 60s. I'd take that every day, all
Yeah,
day.
okay,
But and
yep.
and and, I, and I'm still an outlier. Now I'm thinking about what about the clinical population that I've seen before. Well, they
Mhm.
don't need to squat double body weight or triple body weight. They need to be able to squat body weight, and they can't
Sure.
even do that right now. So yeah, best time to start training was yesterday. Second best time is today. And
Yeah,
I
yeah.
think that most people's strength trajectory, performance trajectory will be an improvement from when they start training. It'll probably peak again if early on in life. If it's probably going to peak in their 20s or 30s, but if you don't start that early, well, your peak's going to be later, and that's fine too.
Yeah. And that's if they've consistently kind of progressively consistently continued to strength train.
Yep.
Now,
Yep.
what if there were somebody like myself that I had to
Asking for
take
a friend.
almost asking for a friend.
Yeah.
I'm my best friend, it's fine. That had to take 7 to 10 years off. I
Mhm.
got a lot of injuries and a lot of things happened to me. The whole book's worth of podcasts there, but essentially I had to take the time off.
Mhm.
Very weak. And then I had to slowly build myself up over time. Um, do you think that my peak was before, or do you
Mm.
think that I would kind of start back over kind of is muscle memory, that's a real thing? Is it a real thing? Or
Yeah.
is it do we start back over?
Yeah.
Like, where
So
will be my peak? There's 2
yeah,
questions
sure.
there.
Yeah. So
I
so
mean my
maybe
friend, not me, my friend.
for your friend. I think
Yeah.
the best way to think about this is that there's maybe a potential or theoretical peak, right? And
Mhm.
then an actual realized peak, right?
Okay.
So imagine you versus your evil twin in a different metaverse. She's exactly like you, but evil, all right? But
Mhm.
and your training history looks as it currently did. Whatever you did
Uh-huh.
when you first started exercising, you did the bodybuilding stuff, you took some years
Traditional
off due to
bodybuilding.
injuries or
Traditional body.
whatever, took some years off, whatever. And then she, on the other hand, had the best strength training program with progressive loading and auto
Mhm.
regulation and whatever, finely tuned. And she did that, adhered perfectly to it.
Mhm.
Well, the theoretical peak there for her and, effectively you in this alternate universe would probably have been earlier in life, right?
Mhm.
But what you actually did was maybe not the best strength training program just from that particular parameter, plus the time
Mhm.
off due to injuries,
Mhm.
which demonstrably prove it was not the best plan for you at the time. So
100%.
so your realized peak is likely down the road, still from
Mhm.
today's current date. It would have
Yeah.
been earlier, maybe, had you been on a different trajectory. So potentially it was higher and
Yeah.
earlier, but, if ifs and buts were candies and nuts and how
Yeah.
the rest of that goes. So I still am optimistic that most people have their best days in front of them from a strength perspective, outside of the rare person who started early on a
Mhm.
really good plan and, that was well suited to them and they were well nurtured and managed over time. That's a rarity. We see it all
Mhm.
the time, even in sport. People with
Yeah.
outstanding talent and opportunities and potential, they get mismanaged, by a
Yeah.
coach, by a team, by whatever. And this is the same thing here. So
Mhm.
I think, yeah, there's the potential or theoretical peak is probably earlier in life for most what I would consider masters athletes, those over the age of 40.
Mhm.
But the real peak is probably later in life, just due to you learn stuff along the way. You get better at realizing what you prefer, what you respond to. Um,
And there's
and
more information
and
maybe.
there's way more information now. Absolutely. Yeah.
Yeah.
So I think there's some mismatch there for the vast majority of people between the potential or theoretical peak and like what's realized. So for you
Yeah.
or your friend,
Mhm.
I suspect your best days are still in front of you from that performance perspective.
Yeah.
Uh, but yeah, theoretically back in the day, you would have been a complete savage. And now you'll
Yeah.
just be a
If
different
I
version
was
of that.
a smarter version. I would have been savage in my 30s, but instead I just decided to gain knowledge.
Yeah.
Do
Yeah.
things
Well,
better.
I mean, you can make the same analogy to like wealth, right? Like, oh,
Sure.
when is somebody going to reach max, wealth? And it's like, well, it could have been earlier had they known all of the what's going to happen in the stock market, where
Yeah.
but you
Yeah.
don't. So,
Yeah.
yep.
Yeah. And I think, and I think, like you said, I think a lot of people, I mean, before we did things not as smart as we do now.
Mhm.
And I had, my friend had a physique goal in mind, not a strength goal, which was a big mistake. I
Yep.
only cared what I looked like because that
Mhm.
was my sport.
Yeah.
And when things started to not work as well as they should, we didn't care. We just trained around it,
Sure.
so just for a certain look. Again, not smart, but we live and learn. And at least I was young enough to get past it and be able to kind of, get better from there. So I want to talk about that to lead into to another episode that I will link for everybody of yours. And I don't have it written down, but I remember what it was kind of coming back after an injury. And I think
Mhm.
that I feel like you've talked about that a lot, and that's something that you kind of specialize in because you have a little personal experience with and was coming back from an injury. So we obviously you there I don't think I listened to or followed up with your CrossFit episode.
Mhm.
You said CrossFit reached out. Did you ever talk to them yet? Or
Next week I'll
oh,
be on their podcast. So I don't know how widely listened to it is, but we'll
super
see how that
cool.
goes. Yeah.
Yeah, awesome. Well, I'll share it. I think we're kind of excited to listen to it in our little community.
Sure.
But you kind of were saying, like, for those that haven't listened yet, he was just kind of saying that CrossFit has brought a lot to the fitness community. A lot of people, CrossFit has a bad reputation. I personally haven't done CrossFit a lot. There's a
Mhm.
couple reasons for it. My husband opened it when I was very, very injured and having surgeries, and I was just out for the count and all kinds of things. And so anyway, he was talking about CrossFit bringing a lot more than just fitness modality. It was kind of CrossFit has brought more access to equipment and a community of exercise and all of those things. But CrossFit has a general name for people that are scared of it, that is prone for injury.
Mhm.
And I have dealt with injuries. You have dealt with injuries. And coming back from injury, I was fed the wrong information. Just stop what you're doing.
Mm.
Completely stop. So I completely stopped out of fear, and not knowing and just kind of grasping on very, wanting to just feel better. So all of my strength went away. So let's talk about training around an injury. And I will link the episode. It's an excellent episode. I've listened to it a couple of times that you did. But coming back after injury, how should we train for that? So I guess kind of go for that.
Yeah, no, it's tough because obviously people, when you're in pain, and you attribute that pain to something that happened in the gym, which
Mhm.
is relatively rare on one hand when you look at like injury risk of exercise and in common modalities, whether it's bodybuilding, powerlifting, Olympic weightlifting, CrossFit, is, relatively rare compared to contact sports, which is not really a fair
Mhm.
comparison because exercise is non-contact. But what I'm getting at is that the
Most of
injury
the
risk
time.
the injury risk is relatively low, 2 to
Mhm.
4 injuries per 1,000 participation hours, but that doesn't mean that people don't get injured. Humans
Sure.
get injured. There's some sort of like baseline risk of being a human, a bipedal organism walking around in this environment of becoming injured, which is non-zero. So I think there's this faulty assumption that if you don't exercise, you have no risk of injury or pain, which is not true. And
Yeah.
then so there's some level, but there is some additional risk of exercising using your body. That's certainly true. Fortunately, the injuries associated with exercise are relatively mild, not catastrophic. They tend to resolve within about 2 weeks. They don't require medical attention for the vast majority of injuries. All that's good news. But what happens if you happen to get one of those injuries? What to do? And to your point, we would not advise rest or like avoiding that particular area, joint, muscle, whatever it is, unless it
Yeah.
requires some sort of surgical procedure to correct, in which case you're kind of waiting for that to happen. What we
Mhm.
really view it is that a particular movement at a particular load, movement velocity, et cetera, any other specifics of the movement, you're just sensitized to. And
Yeah.
so some of that is at the level of the tissue, sure, in some cases. A lot of that, though, is between the ears. And it doesn't mean that it's all in your head. That's not the case. It's just that there is some sort of element of fear and avoidance in the movement. And so if somebody says, hey, just don't do that, you're like, hey, great, happy. Don't have to
And if a doctor tells you that too, and you're scared and you've been
reinforces
injured,
the whole thing. Yep.
yes, and they say, "Oh yeah, well, your days are done.
Yep. Yeah,
You
exactly.
should stop doing that altogether."
Yeah.
And it makes you say, "Well, okay, I guess I'm done."
Yeah, doctor said so. Yeah, and so to again call back to the sort of like what are the clinical goals with blood pressure? It's
Mhm.
achieving a normal resting blood pressure. With obesity, it's achieving a healthy level of body fat. With type 2
Yeah.
diabetes, it's achieving a healthy blood sugar. With injury, it's a
Mhm.
restoration of unrestricted activity. That's the
Yeah.
end goal. And you would
Yeah.
prefer that for most people. It may not be achievable for everybody, but that's the end goal. And so avoiding a particular movement until enough time has passed for you to kind of forget about it, that is one strategy of doing this. However, that tends to not only take longer, but is associated with detraining that we would like to avoid. So
Yeah.
our sort of method, and this is not proprietary by any means, it's finding an entry point that is tolerable, meaning that pain doesn't increase while you're doing it or after the exercise, but that also kind of threatens the area, whether it's a joint, whether it's a muscle, whether it's a movement pattern. And the idea
Mhm.
is like, let's say you had knee pain that occurred with squatting, particularly below parallel. And you were like, well, I can't really squat at my normal weight, my normal tempo, my normal depth without knee pain. We're like, okay, well, what if we change the tempo of the squat, the loading on the bar, potentially the range of motion, potentially how you're squatting with respect to, is it high bar, low bar, front squat, safety squat, bar squat, Zercher squat, goblet squat, whatever. You can go down the
Yeah.
list.
Sport
And
modalities.
you're just trying to regress as far as you need to find that entry point.
Mhm.
Okay, well, maybe it's a leg press instead, or maybe it's a
Yeah.
box squat, like whatever. You can regress as far as you want, but that's your starting point. And then the
Mhm.
goal is then gradually to return back to your not only your desired activities, but also are there other things that you've maybe been avoiding because you're afraid of an injury? Again, to return to this place where you have unrestricted activity. That's kind of where we're
Mhm.
headed. So
Yeah.
the soundbite here is not to avoid or stop activity, but rather change activity to something you can do currently in an
Mhm.
effort to maintain fitness or even improve it potentially, and then gradually work back to where you were and likely better. That's kind of where we're
Yeah.
we're trying to go. And so article, Pain and Training, What Do, top 3 mistakes people make during injury, number of podcasts on low back pain, knee pain, elbow pain, shoulder pain, whatever. We all this stuff. So,
Mhm.
we don't claim to again have this proprietary method, super secret guru stuff.
Yeah.
It's pretty straightforward, but we do recognize that particularly folks who've had significant pain that's been lasting for a long time that they have not been able to self-manage, that maybe some professional care may be useful there at guiding them through this, providing reassurance, providing a individualized plan that may be useful. And we do that too. But in a perfect world, we would just put out the information, people would take it in, do it perfectly, and not need us. That'd be great.
Never gonna happen.
Well, but that's why we put the stuff out free, right? And it's not behind a paywall. So
Yeah.
yeah,
Yeah. Which
that's
I
kind of the
will
goal there.
say, you have a lot of very, again, to be allowed in the noise in my ear is that's a compliment, because it's very valuable. There's a lot of time and effort put into your responses, even written responses. I get a little bit on threads. It's a little confusing for me, but I follow very few people, and for some reason your stuff always pops up, and
Oops.
you, I mean, just the amount of time you take to answer these questions and to answer people politely. I think people need to understand the effort that puts in there, because even the small amount of stuff that I put out, I'm like, oh, this takes a long time.
Hmm.
And so you do have a lot of free resources. So I'm definitely going to link some of those up. So exercise, if you're injured, make sure you can do something you can do, because otherwise you're going to get weak, and
Yep.
it's not going to be fun coming
Nope.
back. And
Nope.
mentally, it's going to suck even more.
You got it. Nailed it.
um, and I also wanted to really quickly, before I know our time limit is almost up, I want to talk a little bit about the BMI. Just you can talk real quickly about it and why it is important, because you get a lot of noise saying, "Oh, BMI isn't important," and I'm so muscular, my BMI is high, and that's just BS.
Yeah.
So let's talk about that real quickly and why the BMI is important.
Yeah. Yeah, no, BMI, body mass index, so the relationship between somebody's height and weight, so weight to height squared. In fact, this was developed a long time ago. Adolf Kettle. It has actually pretty nefarious sort of origins, and that's something about BMI I don't like. It's basically trying to tell different ethnicities from one another. Probably not
Mhm,
a great starting
mhm.
place for this metric. But that doesn't negate its utility per se. It does mean
Mhm,
that the guy who came up with it may be not an unsavory character. That's fine. I'm on board with that.
sure.
But the utility of the BMI is a screening tool for obesity, which is excess adipose tissue, excess body fat. And
Mhm,
as a screening tool, it is very specific, meaning that it has very few false positives. Very
mhm.
few false positives when the cutoff is 30. So if a
Yeah.
man has a BMI greater than 30, I can say with almost 99% certainty that they're carrying too much body fat. With women, it's close to that 96, 97%
Mhm,
specific. Pretty good. And you're like, wow, nice. The biggest dig against BMI is that it is not very sensitive. So there are a lot of false negatives. People who are
mm,
not diagnosed with obesity or screened positive
mhm,
for obesity by BMI because their BMI isn't high enough, but they are
mhm.
carrying too much body fat, which is why the current recommendations for pretty much anyone who cares to weigh in on this is to use BMI and waist circumference together. Because when you
Yeah.
combine those two metrics, you're getting the people who have a low BMI, let's say it's 24 or 25, but their waist
Mhm,
circumference is in excess of what we know to be associated with excess body fat. And so using those two tools together, you get a really good indication of if somebody is carrying too much body fat or not. Uh,
mhm,
People have said, hey, let's use body fat, use DEXA scan, let's use a BIA, bioelectrical impedance, let's use waist to hip ratio, let's use some other metric. All of those can be useful, but they don't do any better than BMI and waist circumference. It's just
mhm.
like, and BMI waist circumference don't expose people to any sort of radiation like DEXA scan, although that's relatively low. They don't cost a lot. They're
Mhm.
relatively cheap. They're
Yeah.
quick to do and
Mhm,
pretty useful. So, and also just as a final thing I'll say on BMI, the idea that there are so many like people that are too jacked just walking around in the environment, right? I don't know if people have been outside lately, but that is not the case.
Not the case.
There are gripes that you can have with BMI, all right, and they are as follows. One, they underdiagnose obesity because it doesn't pick up people that are skinny fat, to use a colloquial term,
Have you ever
all right.
heard of TOFI? It's TOFI.
Uh-uh.
Okay, so
What's
we use that in there's a whole lesson in our cardiac clinic, and it's thin on the outside, fat on the inside, and it
Yeah, yeah.
basically explains visceral fat and the
Yeah.
smaller end of the BMI. Yeah.
Yeah,
Mhm.
so you'd use but a waist circumference picks up on that, so that's gripe 1. Gripe 2
Mhm.
is you'd prefer to have different ethnic and age-related cutoffs for BMI because these do tend to
Mm,
change based on different ethnicities and different ages. So if you said, "Look, we don't have
yeah.
enough data on this particular demographic," sure, that is a
Mhm.
limitation to the test. And then thing 3, I do think BMI is very, very weight centric, meaning that if
Mhm.
you have a high BMI, the stigma associated with that is, "Oh, you gotta lose weight," and we're very weight
Yeah.
focused, and I think that can be a negative. Whereas, look, there are a lot of weight independent related lifestyle changes, exercise,
Mhm.
even changing the dietary pattern. If it doesn't result in weight loss, that would ultimately improve people's health. So I think if we
Sure.
want to shift away from stuff that's stigmatizing towards weight loss or a particular body type, that's fine. But BMI in and of itself is a fine screening tool to use in addition to waist circumference. And I think the evidence is overwhelmingly supportive of this. It'd be very difficult to make an evidence-based claim that BMI is should be we shouldn't use it at all anymore. You could just again come up with the gripes that it's not sensitive or specific, or sorry, it's not sensitive enough because we missed the TOFI people.
Yeah.
And maybe we would want some more demographic data, specific demographic data, to have even better picture of certain populations that we maybe aren't as comfortable with using BMI. So
But it's
those
not
would
a
be the
horrible tool. It's not
I
a horrible tool. Yeah.
in
Yeah.
fact I would say it's great. Yeah, just
Yeah.
again minus the stigma portion for sure.
Yeah, 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 because there's a stigma to it. And then supplements real quick. So everybody's gonna ask about supplements. I'll link some stuff that you have talked about. Vitamin D. I'm just gonna bring these up. Vitamin D, is it important to take? Should we get it tested? Should we not take it?
Yeah, routinely, no. In fact, the Endocrine Society just came up with a position stand that said don't test for it routinely. don't, supplementation guidelines, effectively no good evidence showing that it does much of anything, even in folks who are vitamin D deficient. There are a
Oh,
handful of
wow.
medical conditions that would benefit from vitamin D. Those are people with chronic kidney disease, different gastrointestinal diseases, or previous surgery that limits absorption. But
Mhm.
otherwise, yeah, supplemental vitamin D in general has failed almost every clinical trial that we've
Wow.
assessed it in. Yeah.
Okay,
And
good
some,
information.
yeah.
Yeah, what about fish oil?
It's the same. It's the same
Same?
study.
Okay.
So
It's the
fish
same
oil,
study?
yeah, fish oil. Fish
Okay.
oil would be fish oil is useful. It can lower triglycerides. That's thing one, and it can lower the risk of heart disease or having a major adverse cardiac event in folks with known cardiovascular disease. However, that's really limited to the prescription forms of fish oil, which are fish
Mhm.
oil isomers. There's slightly different chemical structure. The over-the-counter stuff doesn't seem to really do this that well, if at all. And further, there's an increase in atrial fibrillation risk apparently with supplemental fish oil.
Hmm.
So it's not a panacea.
Maybe
Would
you
not
eat fish.
routinely. What's that?
You should just eat fish.
Yeah, we don't know that that is actually beneficial from an omega-3 kind of standpoint, but rather the
Mhm.
dietary pattern that generally includes fish tends to be more health promoting than dietary patterns that don't
Makes
include
sense.
fish.
Yeah.
So, yeah, I do not recommend fish
Save your
oil
money.
in general.
Save your
Yes.
money.
Yes.
Okay. Collagen.
Yeah, collagen protein is on the scene. Most people don't take a ton of it, 10, 15 grams a day, so overall, like, relatively small component of the dietary pattern.
Does it
Doesn't seem.
count towards their protein count, though?
Absolutely. Yeah, it's still
Okay.
protein, and it's still bioavailable. It's just lower quality, but at the same time, once protein is dosed high enough, it doesn't seem to matter where the protein comes from, whether it's a
Mm,
vegetarian source, like plant-based source, or an animal-based
mhm.
source. If you're taking in 1.6 grams of protein per kilo body weight per day, it doesn't really matter where it comes from. You're getting enough. But collagen protein, the evidence on it doesn't really increase muscle protein synthesis or muscle mass. Doesn't seem to do that at all. Doesn't really have any effect on the soft tissue, so ligaments, tendons, or whatever, because it doesn't actually drive
Lots of
connective tissue
skin.
protein synthesis. Yes. So then finally, the thing on skin, there are no studies using validated clinical outcomes on collagen protein compared to a placebo showing a benefit of collagen. So people will say skin elasticity, and they're like, great, well, how do they test
Sure.
that? It's this thing called cutometry. And so basically it's a suction thing that sees how much your skin will suck away from your skin. And there's
Oh,
no minimal clinically important difference that's been established. The inter-rater reliability is wide, and they're not placebo controlled. And so you're like, all right, 3 strikes, you're out. Same thing with
yeah.
skin hydration. They use this tool called corneometry. Same thing. No minimal clinically important difference that's available, not placebo controlled studies. And further, you're like, well, how is this outcome even like reliably measured? And the test that we use is not. That
Yeah.
said, collagen is relatively low risk. It's just expensive. So that's thing one.
Sure.
But we haven't ever even compared it to eating more protein in general. The protein
Yeah.
that you eat is not intelligent. It's not a smart protein. It's not like, ooh, I've got extra glycine or proline or whatever, and I can like go to specific tissues. It just gets digested,
Yeah.
absorbed, and then into the bloodstream, and the body does what it does. Doesn't matter if it's from collagen, it's from animals, from plant, whatever. So my take on collagen protein is overall just not effective based on
So if you
present
wanted a
evidence.
protein powder, just get whatever flavor kind you want, and it would be just as sufficient and a little
Yep,
bit less expensive.
probably
'Cause I
better,
know
in fact.
I supplement with protein powder because I like to get protein, and I'm not gonna probably get all that through Whole Foods sometimes.
Yeah, probably better, in
Um,
fact. Mhm.
Yeah. Okay. So protein powders are okay. And I think there's a bazillion other things, like I said, I could talk to you about. Our time is just about up. I don't, I don't want to take too much more time. I will link a bunch of episodes up that kind of pertain to this. I have them all saved here in my notes. You did kind of talk about on some of your episodes a little bit about, we had some questions about the Ozempic and those types of medications, and why it's another good modality to be able to use in 2024, and we
Mhm.
shouldn't stigmatize it. That I think it's kind of, helping people. So I will put that up. Is there anything you want to say at the end of this?
No, this was great. I love the discussion. I wish we had more time, but, yeah,
Yeah.
this is super fun. So I look
Yeah.
forward to coming back in the future.
Yeah, I can't wait. Thank you so much. And I hope maybe someday, if you don't already have it in the works, you have some type of certification or something, course or something that we
It's
could
coming.
take.
It's
Is it?
coming. It's
I can
coming.
see
Yeah.
it. I can
Yeah.
see it written. But I think that would be so beneficial to just, I mean, fitness professionals alone, but also, like I said, I have all kinds of different audience here, even physicians that might even be able to kind of help you fill that gap too.
Yeah. Yeah. I would love it.
Yeah. Yeah. Very, very cool. Well, thank you so much, Jordan, for coming on and taking time. And I hope you will come back on again and we can chit chat some more.
Absolutely. Thanks for having me.
All right. Thank you.